Hyperventilation system. Calm down. So we want to calm people down. They're freaking out. They have anxiety. You can coach them. My favorite treatment in the book is sing a song with them. So potential causes could be hypoxia, not enough oxygen, cardiac pulmonary disease, infection, fever, pain, pregnancy, drug use. Signs and symptoms could be dyspnea, tachypnea, chest pain, carpopedal spasms. That's a new one. Remember, hyperventilation will cause too much CO2 to be eliminated, so put the patient on capnography and monitor their CO2. If we have a pneumothorax, simple pneumothorax, in the presence of air in the pleural space between the lungs, the lining there, could be caused spontaneously by trauma. If we want breath sounds, breath sounds could be diminished, absent. Patient may be becoming dyspneic and restless, tachypnea. Tension pneumothorax, a accumulation of air in the pleural space that causes tension and obstruction. So if they have JVD, jugular venous distension, right here, there could be hyperresonance on percussion of the lung sounds, subcutaneous emphysema beneath the skin layers, and the patient will become hypotensive in late stages, also known as obstructive shock. High altitude emergencies, acute mountain sickness, common high altitude illness. The person ascends rapidly to over 5,000 to 7,000 feet. Could be headache, nausea, vomiting, weakness, dizziness, fatigue, difficulty sleeping, tachycardia, bradycardia, postural hypotension, and ataxia. Postural meaning that whenever they go to a certain posture, they stand up. I think that's orthopedics actually. But depending, if they're laying down, their hypertension should equal out. Or if they're semi-Fowler or reverse Trendelenburg, then it would be at a normal high state. But if they lose it and they get hypotensive because they stood up or they become straight up, then that's why it's postural. Ataxia is a key sign of development in high altitude cerebral edema, or HACE. High altitude pulmonary edema, HAPE. This is caused by an increased pulmonary artery pressure. Symptoms usually begin 24 to 72 hours after exposure to high altitudes. The most lethal of altitude sickness. Progressive cough can happen, hypoxia, tachypnea, and weakness at altitudes over 8,000 feet. They may develop crackles, wheezes, rhonchi, tachycardia, and cyanosis. Oxygen administration and descent to an altitude that is less than 500 feet. In the adult patient, the average tidal volume is around 500 milliliters. I kind of don't want to go through all these. We reiterated. Let's keep going. Please be a new chapter. Oh, cardiology. My favorite. No. Bro. Okay. We're going over cardiac anatomy. Obvious. Right atrium, right ventricle, left atrium, left ventricle. What's the parts in between? We have the tricuspid valve, try before you buy, goes into the right ventricle, goes into the pulmonary valve, goes to the lungs, comes back from the lungs, and we have the mitral valve, goes into the left ventricle, which goes through the did that wrong, skip the mitral. So left ventricle uses the mitral valve to get to the left atrium and then to the system, which is the body. Other parts, you have the valve anatomy. So there's the chordae tendineae and then the papillary muscles that are connecting to it. So what is a tendon? A tendon connects muscle to bone. Tendineae, chordae tendineae. You're connecting the valve to the papillary muscle. The whole heart's a muscle. Valve order, toilet paper, nice. 3 layers of the heart muscle. So we have the endocardium, innermost. We have the myocardium, think in the middle, myocardium, middle, and then the epicardium, or the pericardium, which would be the outer layer. Peri, epi, meaning around or on top of. We have our SA node. This is the nervous, cardiac conduction. Pretty obvious, nothing complicated we haven't already talked about. The SA goes to the AV, goes to the bundle branches, and you are 60 to 100, 40 to 60, and then this is new, 15 to 40. I always thought it was 0 to 20, but whatever, memorize both numbers. In cardiac emergencies, we have stable angina, we have unstable angina, variant angina, left-sided heart failure, right-sided heart failure, and cardiac tamponade, the myocardial infarction, MI. Angina is a term used for pain in the chest. It occurs whenever the heart's demand for oxygen exceeds the blood supply, and it's commonly caused by atherosclerosis, coronary artery disease, and can also be a result from a spasm in the coronary arteries or variant angina. Am I good? Yeah, I'm recording. There are 3 types of angina, and they are primarily categorized by their cause and duration. So we have stable, unstable, variant. In stable angina, we have is typically sudden in onset, same as unstable. Onset generally with exertion. So let's say you're working out, you're doing push-ups, suddenly your heart hurts. Stable. You can stabilize it by stop working out. It's going to last for 3 to 5 minutes. Subsides with rest and or nitroglycerin if you take nitrostatin tablets of like 400 micrograms. Unstable angina may initiate during rest, so you could just be chilling and suddenly you feel it. It's going to last more than 20 minutes and may not resolve with nitroglycerin. If you have variant angina, this is also called princemetal or spasmodic angina. It's caused by coronary vessel vasospasms. It can occur at rest, similar to unstable, and you may go into it spontaneously with medication, or may go away spontaneously with medication. So how we're going to manage this, we want our 12 lead. Obviously, oxygen is important. Relieve the pain. We want to place the patient in a position of comfort, and we want to administer oxygen. Yes, establish IV access because we might have to start pumping drugs if they go down the toilet drain really fast. Remember MONA, right? Morphine, oxygen, nitrostat, nitroglycerin, and aspirin. Yes. Or fentanyl. Heart failure. Primarily, we are concerned with the 2 types of heart failure. We have left-sided, right-sided. Knowing the difference between this causes, signs and symptoms, and treatments are critical to your successful NR EMT test. So causes of right and left heart failure. We have right heart failure. What causes that? Number 1, left heart failure. Cor pulmonale, right ventricular hypertrophy. Right ventricular infarct, death of right ventricular tissue. We have the tricuspid valve damage, pulmonary valve damage, and pulmonary embolism. If we're looking at left heart failure, you have pulmonary edema, hypertension, left ventricle infarct instead of right ventricle infarct, mitral valve damage, aortic. Where's the mitral valve, right? Try before you buy. No, mitral. Tricuspid is, bicuspid is mitral. Yeah, left side. Aortic valve damage, which is also on that side, cardiomyopathy, and myocardial infarction, which is your number 1 cause, death of heart tissue right there. Signs and symptoms of left heart failure. So right heart failure, we're going to have JVD, jugular vein distension on the right side because it's stopping up from where it's coming from the system, the veins going back to the heart, so that's why. It always goes from the veins to the right side of the heart, so right-sided heart failure. Peripheral edema, just like the jugular veins are swelling up, we're going to have edema and fluid in like our extremities. You're going to see the calves swell up. Ascites, abdominal swelling, so you'll have ascites here. Ooh, that word, Greek, ascites is, it's like vase or something that holds liquid. Or to pour out. So A meaning the opposite of, and then cites to pour out. So instead of pouring out, we have a jug, something like that. Sacral, scrotal edema. You're going to get some swelling down there. That is not you, my friend. Orthopnea, whenever you stand up or move around or adjust your position, you're going to have issues breathing. Hepatojugular reflex, that's a new one for me. Anxiety, yep. Tachycardia, I feel like I'd get anxiety with both of these. But more so, okay, so this is something that can build up slowly. Like this is this is more stable than left-sided heart failure. You're going to have issues with breathing with the left side because everything is coming from your lungs to the left side of your heart. You have tachycardia, you have hypertension, you have pale, sweaty skin, paroxysmal nocturnal dyspnea, trouble breathing, orthopnea, trouble breathing, rales, crackles, because there's fluid building up. So you're going to hear, if you oscillate in the lungs, you'll hear rales and crackles. Pink-frothy sputum, that's a late sign because there's blood in the sputum. Pulsus paradoxus, I have that naturally. Pulsus alternans, something with electricity. Primarily concerned about two types of heart failure, left-sided, right-sided, knowing your difference between signs and symptoms, critical success. Treatment of right or left heart failure. So right heart failure, position of comfort, oxygen, 12 lead, always oxygen, position of comfort. I mean, those just happen regardless. Fluid administration for Starling's law on the right side. Left side, we don't get fluid administration. So fluid administration is 100 to 200 milliliters of normal saline. Nitroglycerin for left side, CPAP for left side, and furosemide, because we're dealing with breathing pulmonary issues. I'm at 11. Cardiac tamponade. This often occurs due to blunt trauma, think steering wheel to the chest. Tamponade carries heavy mortality rate, but we can jump to mortality, so let's review that, right? Steering wheel hits you, if you hit something, swells up, it's inflaming. The heart is surrounded by a sac called the pericardial sac. Sac has 3 layers, just like our, myocardium, epicardium, and pericardium. So we have the innermost lining, which is the visceral, and pericardium, visceral to the vasculature, and the parietal pericardium, and then the fibrous pericardium. So in between the visceral pericardium and the parietal pericardium is 25 milliliters of pericardial fluid. When tamponade occurs, there's an excess of accumulation of fluid that builds up in the pericardial sac. Because the sac is tough, think of leather, doesn't expand well, and with this excess fluid, the lack of expansion puts more pressure on the heart, which prevents it from pumping like it needs to. This causes cardiogenic and obstructive shock. Tamponade can be caused by trauma, can also be caused by pericarditis or neoplasms, also an MI. So Beck's triad, this is what we're going to use if we're looking for key signs and symptoms. What is Beck's triad? We're just looking at this. Well, anyway, if you have JVD, you have muffled heart sounds. Oh, it's for cardiac tamponade. That's Beck's triads. And hypotension. So their blood pressure went down because their heart is swelling up around it and it can't pump like it needs to, which means fluid's backing up here, which means also you're going to have muffled heart sounds because you can't hear through all that fluid. They also have chest pain, dyspnea, orthopnea, narrowing pulse pressure. Electrical alternans, pulsus paradoxus, altered level of consciousness. Our management, ABCs first. Oxygen, IV access, fluid bolus of 20 milliliters per kilogram, and vasopressors. Our causes, if we have cardiogenic shock, right, we have impaired myocardial contractility, impaired ventricular emptying, so left-sided heart failure, tension pneumothorax, cardiac tamponade, and trauma, cardiac contusion, it's bruising. Signs and symptoms, if a systolic BP is less than 80 millimeters Hg, if they are in respiratory distress, chest pain, weakness, and altered mental status. They could also have hypotension, tachycardia, and our management of this is going to be rapid transport as well as a position of comfort, oxygen, as always. Identify and treat the problems that's underlying everything that's happening, and we want IV access and fluid administration. We're also going to consider medications, positive inotrope, vasopressors as well. So yeah, for fluid, listen to lung sounds first because we don't want to put more fluid in if it's already full. So we have 100 to 200 milliliter boluses. Let's stop there.